afternoon, everybody. We are here at MACS, the Maryland Addiction Consultation Service, ready for our next webinar of this month. Just as a reminder, here is the information for MACS in case anybody needs that for the future. And thank you very much to MACS for hosting this month's webinar. The webinar that we are going to be doing today is on Maryland's prescription drug monitoring program, really looking at it as a tool to support the treatment of patients with substance use disorders. I'm Yngvild Olsen, the medical consultant for the Behavioral Health Administration and a MACS clinical expert, and I will be leading this webinar for this afternoon. Disclosures, either financial or commercial interest to report. And I really want to give a big thank you to Kate Jackson and Anna Gribble, both at the Maryland Department of Health, for many of the source slides. Reminder, the Maryland Addiction Consultation Service supports primary care and mental health prescribers across Maryland in the identification and treatment of substance use disorders, as really providing support for the team members that are so important for prescribers to really be able to do the work that they do. Physicians, nurse practitioners, PAs have access to support through phone consultation, training and education, and assistance with resource identification for their patients. Services are free and even regardless of patient's insurance status. And we would welcome all of your questions, your comments, and your feedback. Today's session, we have a couple of, or three different learning objectives. By the end of today, I hope to leave you with a way of identifying the clinical components of the Maryland PDMP, describe three ways of integrating the PDMP lookup into clinical workflows, and then integrating the findings from the PDMP into clinical decision-making when treating patients with substance use disorders. My hope is that we will have some time for questions. If you have questions, please feel free to into the chat box, and we will make sure that we get them answered at the end. This is a brief overview. The Maryland Prescription Drug Monitoring Program was authorized through state-level legislation in 2011. Almost 10 years ago. It went live in December of 2013, so all of the information that you will find in it is no older than 2013. Provider registration was required as of July 1st of 2017, a way of really ensuring that providers, prescribers, people who could make use of the information were registered in such a way that they could access the information. The PDMP is administered by Maryland's Department of Health, and it essentially is a secure statewide electronic database that contains information, detailed information about Schedule 2 through 5 dispensed controlled medications. The program really aims to do two things. One is to assist healthcare providers, public health, and safety authorities with reducing the non-medical use, overdose risk, and diversion of prescription medications, as well as enable the state to conduct surveillance and education about prescribing and or dispensing of controlled medications. What is nice and unique about Maryland's prescription drug monitoring program, that it is hosted by Maryland's Health Information Exchange System, otherwise known as CRISP. So essentially, Maryland's PDMP is embedded into the CRISP system. Why is this really important, and why did the PDMP come about? Well, I think that it's no surprise to anyone that Maryland has been hit hard in terms of unintentional drug and alcohol-related intoxication deaths. And this graph shows you the most recent figures from the report that came out in May of this year. It shows the dramatic increase of opioid-related overdose deaths from 2007 to 2018. And look a little more granularly at what actually is involved in those opioid-related overdose deaths by substance. We can see that we essentially have those three waves that nationally has been talked about. So first was kind of prescription opioids. So there was an increase really between 2009 all the way up through 2016. Then really followed by heroin, particularly dramatically between 2012 and 2016. And then finally, the biggest increase, and what we now are really thinking of as the third wave, and probably the most deadly wave, is that of fentanyl, illicit fentanyl, that really hit the streets in about 2014, 2015, and continues to really rise, as you can see in this chart. It's out because even though Maryland recently saw a decline in opioid-related overdose deaths in the first quarter of this year compared to last year, and even though fentanyl, and many prescribers and many healthcare professionals may say, well, fentanyl is not my problem. I don't have anything to do with that. I don't prescribe it. And same thing with heroin, that when we look at actually the prescription opioid line here, in 2018, we still had a higher number of prescription opioid-related overdose deaths compared to 2007. Even 2008 and 2009. And Maryland had really seen declines in heroin and prescription opioid-related overdose deaths, partly due to significant reductions in Baltimore City related to expansion of access to effective pharmacotherapy for opioid use disorder, which we'll get back to in a little bit later in this webinar. To really highlight that, prescription opioids, whereas they may not be the largest source of opioid-related deaths, they still are an important one. And so one that we want to keep in mind and do what we can to try and actually minimize people's risk. And the PDMP is one aspect of how we can all do that. PDMP's role really in addressing opioid misuse and overdose falls into kind of a couple of different areas, because healthcare providers can be a source of misused prescription medications. Data from the National Survey on Drug Use and Health that has identified that of the people who misuse prescription opioids, the vast majority get them from one healthcare practitioner. So just as a reminder that we have a role to play in this. Secondly, healthcare providers frequently interact with individuals at risk for overdose. Even though you may not be the prescriber of controlled medications, that if you work in an emergency department or a hospital or in a primary care setting or in a behavioral health setting, that you may come across individuals who actually have been prescribed these medications, or are, because of their opiate use disorder and their use of heroin and or illicit fentanyl, are just really at high risk for overdose and harm. PDMP can help enhance the opioid prescribing and dispensing decisions that we make, inform clinical practice, and really eventually protect patients who may be at risk. We need to be also judicious in how we use it, because PDMPs can be misused. When I was talking with others about doing this webinar, one of the reactions that I got from Maryland was, oh, but PDMPs are only there to catch providers or patients doing something wrong and punishing them for it. And that really is not what the goal is of the PDMP in Maryland from a clinical perspective. We want to make sure that the PDMP is not misused. They're not cut off from controlled medications without warning. That there is consideration of possible errors. The system is not 100% perfect, and that we are not making assumptions and judgments made about patients based on stigma or um, uh, false beliefs or bias. How has the PDMP evolved in Maryland? So I mentioned earlier that the provider registration was required as of July 1st of 2017. If folks have not yet registered, it is not too late. You can always do that. And the use mandate, so the mandatory use and query of the PDMP has been in effect since July 1st of 2018. The reason for actually requiring this was because earlier efforts at voluntary query and use really didn't capture the wider audience of clinicians that could actually make use of the tool and the information that is in there. So the goal was and is to promote wider adoption of the PDMP by clinicians. The PDMP has also added clinical resources in addition to the data to assist in clinical decision making, including an element that we will get to later where providers can actually view their own prescribing trends to guide practice change and their own insight into how they are managing or prescribing controlled medications. It is important to add that health professional licensing boards do have the authority under Maryland law to enforce the use of the PDMP and also to use some of the information that can be gleaned from it. However, there are some exceptions to this use mandate. There is no requirement to query the PDMP if the opioid or benzodiazepine that is going to be prescribed or dispensed to an individual, if that individual is, or that patient is going to be getting a prescription for 3 days or less, if they are receiving treatment for cancer or cancer-related pain, and that is the indication for the controlled medications, if they are in hospice or are diagnosed with a terminal illness and are being prescribed medications for those indications. The prescription for an opioid or benzodiazepines is to treat or prevent acute pain for a period of 14 days or less following certain surgical and other traumatic procedures or events. Or if the patient is receiving care in an assisted living facility, long-term care facility, a comprehensive care facility, or a developmental disabilities facility. So just some very reasonable clinical exceptions to the PDMP use mandate to keep in mind. Another exception is that prescribers need to use their judgment when accessing PDMP, because if that accessing would result in treatment delay that would negatively impact the patient's medical condition, that the mandate to query prior to providing a prescription may not hold. If the electronic access is not operational, obviously it's going to be impossible to query the PDMP. And if the data cannot be accessed due to either temporary, technological, or electrical failures. The goal really is to have providers use the PDMP as a clinical tool in helping them make decisions and clinical decisions about patients and care, because it really offers healthcare providers real-time electronic access at the point of care patient's complete Maryland CDS prescription history. Because it is actually integrated and embedded in the the health information exchange in CRISP, that it means that it is also now really integrated into many of the hospital EHRs and the electronic health records that EHRs and other healthcare provider systems use. And so there may be just one single sign-on that you have to do, that you don't actually have to remember 3 different passwords to 3 different systems that you would then need to log into every time you take care of a patient. Thing is that Maryland has been very diligent about working on interstate data sharing for clinical users. So the PDMP in Maryland now pulls in information from West Virginia, from Pennsylvania, from Delaware, and from DC, really all the surrounding states. So that's really kind of an overview of the PDMP and the goals for having the PDMP be available and that data available to clinicians. What do you do when you find concerning situations? This happens, and it will most likely continue to happen. Because patients sometimes do go to multiple prescribers, have multiple pharmacists. Patients are sometimes prescribed high morphine milligram equivalent of opioids and combinations of not only opioids, but also combinations of opioids and benzodiazepines that could have negative harmful interactions for patients. Sometimes have multiple addresses and date of births in the PDMP. And how do you interpret that? What does that mean? And unfortunately, there are sometimes individuals who may try and forge prescriptions for different reasons. And finally, there may be some providers who really are not are practicing. They're practicing outside of standards of care, and they're practicing really kind of outside of their scope of practice in terms of really not being therapeutic. And sometimes the way to identify that is to have, when there are a large number of patients from the same provider, especially ones that have kind of cookie cutter prescriptions. Again, it's just kind of a warning flag. Not that it absolutely says that the provider is doing something wrong, but just as a kind of a warning signal. What do you do when you see some of these red flags? The most important thing first is to get all the facts. Because as I've mentioned, that the PDMP can be misused. So we want to avoid making assumptions about patients, providers, or other dispensers. Following up with patients, having discussions about what you find. Following up with providers, having discussions with them about what you find in the PDMP. Those things are really important steps to take in order to get all the facts so that you can then make appropriate clinical decisions. Confirming the information that you find within the PDMP with the patient and other providers is important. Updating that information when it's not accurate. I had a patient once who I looked in the PDMP and it looked like she was getting benzodiazepine prescriptions and an oxycodone prescription from a provider that we had actually already talked about the visit prior to I checked the information. And when I asked the patient about it, she said, "Oh, no, I did not go and pick up that prescription. I told him I didn't want to take it, but he wrote it anyway. I never went and picked it up." So I called the pharmacy that was listed in the PDMP, and sure enough, the patient had not picked up the prescription, but because the way that the information gets into the PDMP is based on when the pharmacy fills the prescription, not necessarily when the patient picks up the medication. So that information was still in the PDMP under her name, and the assumption that someone could have made was that she was still actually either getting it or taking it, picking it up, but in fact that really wasn't the case. Interpreting the results from the PDMP within that context of a complete patient assessment, including if the patient is working closely with another provider on some of these concerns, that is really important because the PDMP is one piece of information at one given time, and although you can actually get a trend and a historical pattern, it is just one piece of information. Just like a hemoglobin A1C or a hepatitis C viral load, um, historically, that historic information is also just one piece of clinical information to consider. Um, there are just, as I mentioned, there are a couple of things that we just need to also remember about who are the PDMP reporters and when are there exceptions? When would you either not find information in the PDMP that may just reflect someone has been getting control medications, but it's just not in the information is not in the PDMP, or as my example showed, when may there be errors? So the dispensers that are subject to reporting information on prescriptions and prescription filled into the PDMP include hospital outpatient pharmacies, community and retail pharmacies, mail order pharmacies, for example, that are dispensing to Maryland addresses, and then practitioners that actually may be dispensing controlled medications out of their office. That probably is pretty rare these days, but just as something to keep in mind. The exceptions to that include inpatient pharmacies, long-term care facilities, treatment programs that are dispensing methadone and buprenorphine, and also cannabis dispensaries. There's been a lot of discussion over the last few years about the last two, both at the federal and at the state level. But for right now, neither of those entities are able, by either federal or state law, to provide information into the PDMP. Something to think about and just remember when you're also then asking patients about where they get their medications, and if you have drug test results, for example, that you may also want to clarify with patients. And really kind of following up with patients as the first step when you find concerning information in the PDMP. It is really a clinical tool to have conversations with patients, trying to figure out the reason, perhaps, for the concerning behavior or the concerning information that you're actually seeing. Because the patient had to change providers because of insurance coverage. Maybe going to a clinic where there are a number of residents and they see a different provider every time that they go. Misunderstandings or miscommunication regarding pain management agreements, or patients who may have some limited health literacy, who actually really have just not kind of quite grasped exactly how they're supposed to take a medication, when, and what to really do with medication when actually need, because of their pain, need to take more. It may represent that they had transportation issues that make it difficult to access a pharmacist, or unstably housed. Maybe they've actually needed to use more than one pharmacy because they never really know exactly where they're going to be across either the city or the state. It may also be that other providers aren't checking the PDMP before they prescribe something. You may be the person who actually is identifying some concerns when they haven't. It may be that patients have underlying mental health issues that make pain really difficult to manage, and the way that they actually are managing their mental health issue is through the medications that they have been prescribed that may actually not be really effective or appropriate treatments for those mental health issues. Finally, medication may have been stolen or diverted, and patients may actually really be at risk for an opioid use disorder. And that may be the underlying condition that you are just kind of getting hints at. And so it may be that really screening for and trying to make a diagnostic assessment for that condition may be important. People really do need to see that you care before they care what you think. This is something that I have learned over time and experience, is that honesty and openness in a patient-doctor relationship or patient-provider relationship really involves a tremendous amount of trust. And if people think that you and believe that you are on their side, they will be much more forthcoming with information that then actually will help them and help you make good clinical decisions. In terms of follow-up with providers, because that was the second step that we talked about, that if you see something concerning within the PDMP, you want to confirm that information with the patient's other providers. Call them up. When patients are being cared for in specialty behavioral health, and particularly specialty addiction treatment settings, you want to make sure that you have the appropriate releases to be able to do that. But in talking with patients, you can assure them that really what you want to do is actually coordinate their care with the provider so that together you all can actually make good clinical decisions that are going to be helpful for the patient. Talk to the provider, discuss your concerns, document those interactions, and use that information to make those appropriate clinical decisions with the patient, not just for the patient. And finally, I wanted to talk a little bit about kind of some of the newer clinical tools that are now available in the PDMP in Maryland. The first is what has been called an alert center, and specifically non-fatal overdose alerts that are now being included in the PDMP. Also show you the delegator dashboard as a resource to help manage delegators, and give you a little bit of a hint of what the DEA self-audit is about. It actually provides a listing of all the prescriptions across all the patients based on the DEA number. You can kind of get a sense of what your prescribing pattern looks like across your patients. So this is just a snapshot, the screenshot of what the non-fatal overdose alert will look like if you have a patient who has had this happen to them and they have been taken to an emergency department or admitted to a hospital. And I pulled out this note because, as I mentioned earlier, that the PDMP is not telling prescribers, the information in there is not really providing license to abruptly discontinue prescribed medication, because that really has its own inherent risks. The notification for an overdose alert or the information that is in there is meant to aid in clinical decision making, really including assessing the need for referral to treatment or coordinating with other providers. So, clinical decisions are individualized between a provider and their patient. It may or may not affect the decision to prescribe or dispense controlled substances, but it really should not replace clinical judgment in providing appropriate treatment. The providers can contact the Maryland Addiction Consultation Service at the website listed, and we will include the information at the very end if they have further questions. So what you will see on the overdose alert is in this yellow bar that there's been an overdose alert, and that the patient may have experienced an overdose. It will list the number of the overdoses over the past 3 years, the event date, the source, so the hospital system where the patient may have been taken, and really then based on the ICD-10 diagnostic codes made at the source facility, what actually the poisoning may have been related to, or what the overdose may have been related to. It may say heroin, it may say unspecified narcotics, as it does here, it may say fentanyl. That really is dependent on how this got coded at the source hospital. So it may even be that the overdose actually may not really have represented an overdose. Perhaps this was something that happened and a patient was given this diagnosis. But again, really important to follow up with patients when you see this to understand exactly what happened. The overdose, though, assuming that that is really kind of what has happened with a patient, may be an opportunity to start patients on effective treatment for an opiate use disorder. What I have shown you here is some data from a study that Mark LaRochelle did in Massachusetts, where essentially they followed people an index non-fatal overdose and looked at their cumulative incidence of all-cause mortality, as well as then specifically opioid-related mortality, months out from that index non-fatal overdose, and compared patients who actually were in treatment compared to patients who were not in treatment for their opiate use disorder. And as you can see, that really the patients, this top line, the patients who were not in treatment, that's this straight line here, the complete line, black line, patients had a higher cumulative incidence of all-cause mortality, almost up to 6 times, compared to patients who were then actually offered and engaged in opioid use disorder treatment with opiate agonist therapies, and that much of that difference really had to do with the fact that then had a fatal opioid-related overdose event, at least within the year, and we're at much higher risk for that within the year after that index non-fatal overdose. So having had an opioid-related non-fatal overdose event puts patients at much, much, much higher risk of having a fatal such event within the year following their overdose. So really something that we need to pay attention to. And we can reduce that risk by getting people into effective treatment for their opiate use disorder when they then return to care. That may include starting people on buprenorphine, includes referring people for methadone to an opioid treatment program, or referring patients for a higher level of care. And Max can absolutely help with providing some of those resources as well. The other element of really kind of trying to help expand the use of the PDMP is making sure that we can get it into the. So one of the ways that we talked about was that there may be single sign-ons through an electronic health record that allow then for really quick access into the PDMP. But the other such assistance comes from the use of delegates. Prescribers and pharmacists who are required registrants for the PDMP can actually delegate their authority to healthcare staff that then actually are able to obtain their own PDMP user accounts as delegates through CRISP, and then they can actually query the PDMP data on the behalf of their prescriber or pharmacist. And that can be extremely helpful to support the integration of PDMP into practice workflows. They, as part of either an initial check-in process for patients, as part of a visit with an MA. MAs are great PDMP delegates. And as you can see, delegates may actually include either licensed or non-licensed clinical staff that are employed by or under contract with the same professional practice or facility. And prescribers and pharmacists can actually have multiple delegates. So if you have 2 MAs or an MA and a nurse that work with a prescriber, both of those could actually be delegates. Delegates can query the PDMP on behalf of multiple prescribers. So if you have 3 MAs that work with 3 different prescribers, or you have 1 MA that works with 3 different prescribers, that one MA can actually query the PDMP on behalf of all 3 prescribers. Delegator dashboard looks like, or where it's located rather, in the CRISP single sign-on, and when you click that, you will actually then be able to see that as the delegator, all the individuals in your practice who have a delegated account, and you can then either remove them, add them, or confirm them. The last new kind of advancement to the PDMP that's been made over since 2017 is the DEA self-audit. And as I mentioned, it provides a listing of prescriptions across all the patients of a particular practitioner based on that prescriber's DEA number. And it is only accessible to the individual prescriber, so no one else really can actually see this. But it's an opportunity for kind of to view and understand your own prescribing trends. It has also been able to be used as a tool to audit potential fraud concerns. So for example, if the prescriber sees something concerning in the PDMP and prescriptions that they actually either don't recall or really know that they did not write, then using the DEA self-audit can be a way to see, for example, if a prescription pad has gone missing or if there's concern for that. Summary. PDMP contains a wealth of prescription data and information, contains information about non-fatal opioid-related overdoses, and its integration into CRISP really makes it so that the tool itself provides useful clinical information. The single sign-on through an EHR, the use of delegates, and understanding that query mandate help to integrate the PDMP check into practice workflows so that it becomes just that that we take care of patients and do business. But we want to really make sure to avoid making assumptions, what I kind of call trust but verify, and make sure to talk to patients about concerning information that you find in the PDMP. It may be that there are very reasonable reasons for why we see the information that we see, and jumping to conclusions and making clinical decisions on those erroneous conclusions may be very detrimental to patient care. Because when people have an opioid use disorder, for example, there are very effective treatments that we can provide that reduce people's risk of overdose, that can help not only reduce their mortality, but their morbidity and improve their overall quality of life in the end. That's it for this webinar. Please feel free to send us your questions in the chat box. If you think of a question after the webinar ends, you can also email Tracy Summer at tsummer@som.umaryland.edu. We want to remind people about an upcoming event for prescribers on Wednesday, November 6th. It's free. It is a half and half, so a 4-hour-long MAT waiver training that is going to be presented by Eric Weintraub. The other 4 hours are done online. This is happening on the Eastern Shore, and we really hope that people can join us. If you have any questions, again, also email Tracy Summer at the email on your screen, and we're happy to take questions. We have one question so far. How do we assign delegates? Great question. So in order to assign a delegate, the delegate actually should go on the CRISP website. It's the Chesapeake resource. Now I'm going to forget what it is. The CRISP website. But if you Google CRISP, single sign-on, and that has, or the Prescription Drug Monitoring Program in Maryland has information about how a delegate can actually sign up. They need to initiate account request. There are some pieces of information that the delegate needs to have to get that account, including a photo ID, state-issued photo ID, They need to have the name of the delegator, the email information for the delegator. But it is a relatively quick process to fill out a brief online application, and then the delegator will get an email to, once the application has been processed, to then approve and confirm the delegate